because it is a strength to be able to think about one's own mortality. If you want to help people who may someday face their own end of life, if you really want to help them cope with their emotions, you need to be able to cope with your own emotions, which is why I asked that question. Secondly, being aware of one's own mortality helps you to value life. When you are able to think that this life is temporary, it is tentative, that it is provisional existence, then we perhaps would be able to think of meaningful ways to spend our time rather than pursue things which in the long run may not be meaningful at all. So that's why I asked that question, and maybe at some point of time, you should be giving this point some thoughts. What we are going to try to do today is to talk about helping people who are close to the end of their lives. And how we can care for them. Maybe think a little bit about how we are caring for them. I expect that the majority of people, or almost nobody, would have had a classroom session on caring for people at the end of life. Nevertheless, you and I know that that's a time when patients and families desperately need our care. And we, despite our medical training, find ourselves unable to cope with that. The patient could be in any of these states of mind. You remember this. You have had this talked about in your communication session, I am sure. Elizabeth Kubler-Ross described these phases. The patient could be in any of these phases. It's up to us to find out where they are and help them appropriately. Because if you don't know where they are, just going and preaching to them is of no use. It would be great if we can help her to come to acceptance. She is thinking, oh my God, I am young. How can I leave my young children and go? Naturally, it's very tough. So what you do very often, because we don't know what to do, we abandon them. Instead of that, let us try to help them as much as possible. And that's why I said, maybe the best time to start thinking about your own mortality is now. And as a doctor, I'll remind you that as officially defined in India, your duty of care is to mitigate suffering, to cure sometimes, to relieve often, and to comfort always. There exists no exception to this rule. In our country, unfortunately, the poor get no care at all at the end of life. The middle class also do not know how to go about it. They go from here to there, from system to system, and from hospital to hospital. And the rich do find their destination, which unfortunately is on ventilators in intensive care units. I see that among the people who have logged in today, Raju, how many participants are there?
29 now, sir.
Of the 29, somebody or other, I know several people would know of people who died, who loved ones, a close relative, a member of the family who died either without pain relief or worse, in an ICU. Is there anybody who wants to share a personal experience in your own family?
If you want, you can unmute from your end and speak.
Please unmute and speak.
Good afternoon, sir.
Sorry, your whoever is speaking is not audible.
With your permission, can I?
Who is speaking?
Dr. Vandana, sir.
Good
Dr.
afternoon, sir.
Vandana.
My name is Dr. Vandana.
Yes, Vandana.
Can you hear
please
me,
speak.
sir?
I can hear you,
Yeah,
Vandana. Please speak.
Yes, sir. With your kind permission, I would like to tell this incident related to one of my relatives. So he was diagnosed to have acute lymphoid leukemia, and then after which it was recently diagnosed. He went for some treatment, and then it was found that he had some low blood pressure, and he was put in the ICU. And then subsequently, they said his breathing is that good, and then he was put on NIV. When he was on NIV, he kept pleading that I don't want to stay here. Please take me home. I want to be at home. I want to be at home. But then, because his condition was told to be serious, the accompanying relatives thought that it is better to keep in the ICU. And by the next day morning, he was no more.
Vandana.
Uh,
Vandana, what are
none of the relatives close to him when he passed away.
Vandana, what do you feel about that
Yes,
day
sir.
of dying? What are your thoughts about it?
Yes.
Vandana, what are your thoughts about the way he died?
It was not a good death, sir, where his wishes were not fulfilled. So this is not the death he would have wanted to have when he would have thought about it.
Why do you think he wanted to be out of that ICU? Just imagine from his.
Because he was not. Yeah, because he was not near his children. He
Yes.
wanted to be with his wife, with his children, and in the ICU, the restrictions about visitors are there, visiting hours. So,
Thank you, Vandana. Thank you for sharing that story. And there are other people
thank you,
who would
sir.
have similar experiences who have not spoken, but some of them may be so painful that they don't want to speak. For that man, remember that one day, the last day of his life, is a whole lifetime for him. Have you thought about it? For a human being in the last day of his life, that one day is the whole lifetime left. And at that time, his wish to have his loved ones around him, holding a hand, maybe wetting the lips, giving a kiss, that is so frightfully important. And unfortunately, that is not the way it happens nowadays if you have any money on the pocket. The poor die better than the rich. This woman may not get pain relief, but at least she has those few drops of water going down the throat, given by a loving hand. Let us have this clear. If a disease is not curable and the end is coming, the first and foremost objective is to make the person being as comfortable as possible, physically, emotionally, socially, and spiritually. In this case, kind-hearted doctors were treating his oxygen saturation and his blood pressure, not him. He was uncomfortable physically with the NIV, emotionally because he was not able to receive love. He was isolated and abandoned by the family for all practical purposes. And spiritually, he would have been totally distraught. Without palliation, dying means being in pain and other symptoms, may be breathless, psychological and social suffering, disconnected from the world, and without meaning to life. Whereas the families themselves have then to live with memories of suffering, with guilt and distraught for the rest of their lives. That person's family that Vandana talked about would be sorry whenever they think about the person, not only because they have lost the person, it is not only the grief of lost, but it would be also sorrow of the not having fulfilled his wishes. Whereas with palliative care, instead that one gets physical comfort, connections, and meaningful life. Physical comfort, let me particularly mention that. Sometimes when an elderly person in his or her 80s or 90s fall down and have a fracture of the femur, and if it comes to a question of surgery, what is the best thing? To give the person the choice of surgery or to leave the person alone? What do you think? Pratima or Neetu, what do you think? What is better? Please unmute and speak. Pratima,
Hello.
what do you think,
Hello.
Pratima?
I think, sir, if surgery is not beneficial, I mean, if it is not going to, it's not going to improve the condition of the patient, then I think it's better to provide the comfortable care to the patient, and his last time should be with family, like not to just leave him alone, like he should be with the family. And
But is
care
it
should be taken to make him as comfortable and as free from pain
very good?
and provide symptomatic relief.
Pratima, let us also think from the person's point of view. You said if surgery is not beneficial, the person has a fracture of the femur. Without surgery, the person will never walk, will be bedbound for life. With surgery, there may be a significant risk that the person may die. There is also the possibility that the person may get up and walk about. Place yourself in that position of the old woman. What would be better? Being bedridden with a malunited or non-united fracture forever, or take a risk and get what mobility you can?
Sir, it will also depend on the age of the patient.
Yeah.
What are the
Wait a
chances
minute,
of
Pratima. Pratima,
surgery?
hold on. I already said a person in the 80s or 90s. So let me give you my answer, Pratima.
Okay,
I
sir.
am closer to that age than you are. Therefore, I can say with confidence. Sunil, are you here?
No, sir, not yet.
Not
Mm.
yet. Raju, in the whole group, you may be the only one who is listening to me. So I might as well let you know. If I am in that position, even if the surgery is risky, if there is a possibility of me walking again, I want to walk. I do not look forward to a whole remaining lifetime in bed. Every change of position every 2 hours causing me agony. So you will balance that. As Pratima said, you will balance between the positives and negative. But because surgery is risky, condemning someone to lifetime of being bedridden state is not comfortable at all. It's horrible. So you will emphasize on not only on physical comfort, but also on a meaningful life. And then even if the person is dying, the families will be able to remember not the horrendous pain and suffering, but some time they have had together, some relationship, the satisfaction that they have done their best. And most importantly, please remember, even if the person is apparently unconscious or sedated, don't stop talking to him. Assume that he or she can hear and understand. Keep communicating. What do we lose? Suppose you go in and say, Uncle, I am so and so. I just came to see you. And you may give some family news. Uncle, do you know so and so is getting married next week? Why not? Keep the person treat the person as a human being and look after the family also. And if there are religious rights that are important for the patient or family, facilitate them. Parthasarathi Shaw was a former financial advisor to the Prime Minister of India. In this article, for which I have given you the link, you can read the article. He writes about his mother's experience. He was told that the mother's condition is not salvageable, that she is dying. But even on the day of her death, a liver function procedure was done. What's the use, he says? They said no use. Parthasarathi Shaw asked, then why are you doing it? We have to keep trying till the last moment. Trying for what? To keep the liver functional? Or is it to keep the person feeling good? Sometimes you have to ask, are those investigations necessary? Why subject this helpless woman to one more venipuncture or another procedure? Why is she still getting the multivitamin tablets when she is dying? What good can the cholesterol medication do? And would you still do invasive procedures? I will consider two procedures important, even in somebody who is close to death. One would be a pleural effusion to reduce the breathlessness. Another would be an ascites tapping to reduce the breathlessness. If any procedures or medication will now be used only if it is beneficial for the patient's welfare, and particularly be mindful of children as caregivers. Because the father was running around looking for money and the mother had become psychiatrically abnormal, this girl, this 10-year-old girl, was thrust into the position of the only caregiver for the 1.5 years child. You can imagine. And very often we refuse to see that girl and just keep giving her instructions. Children naturally deserve special attention. At least somebody acknowledging the suffering, trying to reduce. How do you feel? Are you able to sleep? Is there anything I can do to help? Those things matter a lot. And about intensive care for the dying person. This article also perhaps it would be a good idea to read. Sindhu writes that her 84-year-old father, her best friend, was enduring raw intrusive medical procedures against his own wish. All skin and bones, he looked defenseless and at the mercy of doctors, his arms tied up, vulnerable and agonized. In a dying person, if you put a tube into every orifice, they will try to pull it out because that's making them uncomfortable. Then you tie them up. This is assault and battery. Friends, I don't know which one of you is going to treat me when my time comes. Please do not tie me up. Sedate me if necessary. Physical restraints are cruel and barbaric. If necessary, it should be chemical restraint, even if that means sedation. Vandana, you earlier mentioned the intensive care in a person with malignancy, right? Raju, Vandana, it was Vandana,
Yes, sir.
right?
Yes, sir. Yes, sir.
Vandana.
Yes, sir, I'm there.
Vandana,
Yes, sir. Yes, sir.
This National Cancer Grid.
Yes, sir.
National Cancer Grid is a collaborative of more than 350 cancer organizations in the country. And together, they have come out with this document, guidelines. And that guidelines say, Vandana, your relative, do not treat patients with advanced metastatic cancer in intensive care unit unless there is an acutely reversible event. It's a very clear guideline. Unfortunately, it was being violated. It's being violated not only in your hospital, practically in every hospital around the country, in India particularly, this is happening. If your Vandana's family member was subjected to non-invasive ventilation. If that is stopped and the person dies, it is not mercy killing. It is allowing natural death. Euthanasia is killing. I am not saying this. This is the statutory body, Indian Council of Medical Research guidelines. Euthanasia is killing. Withdrawal of artificial life support is allowing natural death. Passive euthanasia is a misnomer. There is no such thing. Because euthanasia is killing. Allowing natural death is not killing. In this situation, when, as Vandana said, every hospital in the country is doing artificial ventilation, even in advanced incurable illness, how can I protect myself? India does not have a law covering end of life. Advance directive or living will, according to a Supreme Court judgment of 2018, will be valid. Friends, I have written it. Arun Swadi, if one of you is treating me, please remember this. My wife and my children have a copy of this in advance directive, which clearly says if I have an incurable illness, I should not be subjected to intensive care or to artificial life support measures. I have named my nephew, who is a lawyer, to take surrogate decisions for me. And according to the Supreme Court judgment, you doctors have the ethical and legal duty to respect my wishes. There are a few impractical procedures. According to this judgment, advance directives can be valid. Withholding and withdrawing life support is permissible. But the court also put in some impractical and complicated process which simply cannot be followed. The court also called withdrawal of life support passive euthanasia, which, as I explained earlier, is a misnomer. So where does that leave us? Unless there are controversies, if there is a discord, difference in opinion between you and the family, it is difficult. If there are two family members are fighting between each other, there is a problem. But the lawyers advising ICMR have given the clear recommendation that unless there is a difference of opinion, the doctor's duty of care becomes valid. Your duty is to mitigate suffering. Your duty is not to prolong the heartbeat by 24 hours by ventilating. Your duty is to cure sometimes, relieve often, and to comfort always, not to cause suffering by artificial life support. There exists no exception to this rule. So this is where we are, friends. We do not have an answer to every situation in our country because India doesn't have a law covering it. But according to the current situation, doctors have to perform their duty of care, of mitigating suffering. Doctors do not have a duty to prolong the heartbeats in incurable illness. No document anywhere, legal or ethical, will say that you have a duty when somebody is dying to prolong life by a few more hours or days by artificial means. No such thing. There was this document that I have given the link for. It's a document from this year, 2022. The Lancet Commission on the Value of Death. They have given several recommendations. I'll mention some of them for your benefit. 1. When you provide healthcare, management of suffering should sit alongside the extension of life as a goal of healthcare. Your duty is not only to extend life, to give antibiotics or to give other treatment, it's also to manage suffering, whether or not a patient is dying. Education on death dying and end-of-life care should be in the curriculum of every health and social care student and in continuing education for practicing professionals. Hey friends, what do you think? Is this in our curriculum? Now, MBBS curriculum? Kanmani, do you know? Neetu, Naveen? Actually, from 2019, officially, end-of-life care has been included in MBBS curriculum. So the medical students who joined year before last or 3 years back are expected to learn end-of-life care also. But there remains a question, who will teach them? Because of the 275 or something medical colleges in the country, only about 40 have any palliative care at all. Others wouldn't know what to do. The Lancet Commission report also says that patients and families should be provided with clear information about the uncertainties as well as the potential benefits, risks, and harms of interventions in potentially life-limiting illness to enable more informed decisions. What it means is, this information should be given early. Vandana mentioned the patient's family. That family and the patient should have been told early enough. This is the situation. We will continue to provide everything we can to keep you as well as possible. But you will not go and make a recommendation for intensive care. Instead, you might say, at this point of time, his condition is deteriorating. Your condition is, your blood pressure we know is dropping. We'll try to keep you as comfortable as possible. In the meantime, with the remaining time you have, is there something that you would like to do? And the person says, I am giddy, I want to sleep. That's all. Or I want to see my child, or I want to see my parents. We'll try to satisfy their wishes. So, to overcome the current cruel treatment of dying people, the first requirement is that you and I and all doctors have to understand what our duty of care, that it is to relieve suffering, and that relief of suffering should sit alongside extension of life, not one or the other. Family's attitude and society's attitude are huge problems. This will need to be discussed further, and they need help to take decisions early. Any of you, have you had the situation where the children want to keep the elderly person at home when incurably ill, but the relatives keep on harassing them? Hey, why are you not taking him to hospital? Why don't you take him to the big hospital? Are you afraid of spending money? You don't want to spend money on your own dad? Do these things happen? Has anybody had this happening in your own personal experience? Arun, Swati, Revati, Fatima, Ammalu, anybody has had this experience?
Sir, Dr. Ashwin says yes.
Ashwin, you want to unmute and speak? Share
So
your
I think
experience.
yeah, I think it is it's a common thing for people to comment and give an opinion, but families need to be well educated to understand what has been done. Because the part of this country which I practice in Punjab, it is very difficult to people get volatile very fast. I mean, I had blocked my video because I was with a girl who's 16 years old, who we started a morphine midas infusion. The mother was totally not accepting. She was literally shouting at me. I mean, this patient has been with us for almost 10 days now. And we had sent her back on a oral morphine, came back to casualty, gasping. So I said, don't send any blood test. Just take her in, put on a midas morphine infusion, and keep her comfortable. Now, the mother and the brother are totally, I mean, it's emotional. So they kept saying that we went there. Some doctor, my uncle said this, my auntie said this. You're not doing enough. So opinions come, but for you to understand, for people to understand all this, it takes a good level of education actually. I didn't take her to the ICU, I put her in the ward only. But uh, when the bill comes, it will be a bigger problem. You will have to write off that bill from department funds because I know that's how it's going to end. But that's the reality, sir.
Ashwin,
There's already a huge crowd.
Ashwin, do you think the mother could be in one of these states?
She's in denial and anger, sir. And bargaining. Yeah, because
Denial
now the
and
bill will
anger
come, they
and
will refuse to
bargaining.
pay.
So Ashwin has given us an important question to discuss. This is the reality. As Ashwin said, I also acknowledge this is the reality. Can anybody think of some way of resolving this problem? Part of the solution is starting communication early. If on the last day you say it is no use, let us give up, they cannot take it. They have to go through all these stages. So friends, one of the important things for us to do is to be brave enough to start the conversation early. Meaning you have had your communication sessions as early as possible. When the disease seems to be incurable, we should be sitting down with the mother and the brother and saying, what do you understand about your daughter's illness? And they say, my doctors have said such and such things, but we are sure she will get better. And you might say, certainly I also hope she will get better. We will do everything to make her feel better. But at the same time, sometimes it's good to be prepared for the worst eventuality also. Let's hope for the best. But if she does not respond to the chemotherapy, we will have to think about what needs to be done. And on that day, the mother may say, no, she will get better. I'm sure she's a fighter. I am sure she will get better. Okay. In which case, we may leave it for that day, but I won't leave the matter altogether. Next visit, I may sit with the mother again and say, last time I said something and you were very upset. And they may say, yes, and also on. But I'll keep trying to get the person to come to acceptance, still remaining hope. Continuing to be hopeful, but still getting prepared for the worst. Kanmani, I see you. We have the record of the youngest participant at our course. Raju, have you made a note of this? Better get a screen photo. Kanika, Kanmani, what's her name? Oh, Kanmani has gone away. No. Let us stay there. Hey, we were enjoying seeing her. What's her name?
No, he is Milan Daniel.
Oh, he. Sorry.
So sorry.
What's the name again?
Sir?
What's the name again?
Nilan Daniel.
No. If he wants to be on your lap, by all means, feel free. We appreciate you for joining the session, even when challenged by domestic requirements.
Yes, sir. Today my caretaker has not come, so it's quite difficult for me. It's okay.
Okay. No. But what I'm saying is, Kanmani, it's okay if he climbs back onto your lap.
Okay.
So, Ashwin, I know that
Yes,
these problems cannot always be solved, but you tried. I appreciate you for trying. But if we do not do it with the family's consent, very often it's impossible to solve it. See, that mother will continue to be angry for the rest of her life if she feels that an injustice was done to the daughter. So there has to be this attempt, wholehearted attempt, started as early as possible to get the family to come to acceptance. And that one thing that I very often do with children of elderly parents is we have the conversation. We have the conversation about what needs to be done, and then I may bring it up. But at some point of time, an uncle or aunt may come and ask, why are you keeping him at home? And then they may blame you for keeping him at home. What will you do at that time? And generally they will say, yes, 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 I see that can be a problem. And I'll say, Mr. So-and-so or Miss So-and-so, I think right now you have to take a decision that you will do the best for him or her, and not the best that something to please somebody else. What your uncle's concerns are important, but your mother's needs are more important. Let us take a joint decision that we will do the best for this person. So when we prepare them like that in advance, things are a bit easier. But Ashwin, these problems are not necessarily solved for everybody. It is not the same for everybody. That is true. And sometimes we find ourselves in difficult situations. Do not think that I am making light of the problem. Nevertheless, it's important for us to realize what is right and what is wrong. Ashwin, deciding against artificial eye support for that young woman was totally right on your part. Of course, along with that, we should be trying to get the family to understand. Because Ashwin has very well brought out this problem. Ashwin was very sure of what his duty of care was. But the family and maybe extended society was not agreeable. And very often,
It's actually not very comfortable for patients also to see their near ones struggling at some point of time. I think, I mean, this is my personal part. I mean, this patient has been with us only for 10 days, was treated outside and then comes to us. So we've done this session multiple times from the beginning. We've explained, and then they went home for supportive care 2 days back, and they came back again because she was worsening. I mean, it is probably difficult to see somebody gasp in front of you at home. So a lot of things like when my grandmother died, we were sure. I mean, we didn't take her to the hospital. My parents were doctors, so it was a peaceful thing at home with everybody around. But that level of education to expect from a lot of other people in this country, I don't think we are ready for that right now. A hospice sometimes, I mean, I feel that some point of time patients having recurrent ascites, needing IV fluids to or some feeds, to manage them in a poor in a laborer's home may not be a very easy thing. So this that's where the disparity is what I feel. I mean, it's about understanding.
Ashwin, if the home situation is so bad, it's okay to hospitalize them. What is not okay is to isolate them in an intensive care unit. And then, as you say, the family's perception may be different. Despite your 10 days of efforts, they were still not accepting. But please don't generalize. I have been in this business for 27 years. And yes, we do come across that situation where the family is totally able to accept. But in the majority of cases, people have common sense. And it's not a question of education. I find that the educated, rich society finds it very often harder. The poor people are accepting of death easier. If we talk to them in their language, they accept much, much better. But as we are becoming more and more civilized, and then nuclear families, death is an unfamiliar subject, then the problem is much more. So let us not generalize. For one thing, let me come back to this, Ashwin. Your duty of care should be clear for you. This is what you want to do. But you also realize that you cannot do this without the family support. So then when the family is fighting you, maybe you will have to work some kind of a compromise. I see what you are saying. We'll do everything to keep the person alive as long as possible, provided we do not inflict any more suffering on them. But suppose the family still says, no, we don't want to keep him here. We'll take him to ICU, try to do your best, etc., etc. Sometimes it may be necessary to do that. I accept that. What is the legal position? As I said, the legal position is unclear in our country. I already showed you this. India does not have a law. The proposed law was proposed but has been abandoned. So when there is no law, a Supreme Court's decision is valid. According to that decision, advance directives are valid. Withholding and withdrawal of life support is permissible. But they have put in complicated process to make it happen, which will become a problem when there is a fight between family members or when the family is fighting you. Ashwin, I quite see your problem. If the family is saying, no, take him to the ICU and do everything to keep him alive, keep her alive, you will take her to ICU, do whatever you think is appropriate, not beyond that. The family is unlikely to say, keep her on a ventilator forever. That's unlikely to happen. They may not specify ventilator. So unless a ventilator is actually indicated, you wouldn't do that. It will not help to pick on a fight at this point of time. We want the family on our side. Now, what it remains is, if there is no conflict between the family and us, then we will do by what is our perception of duty of care for the person's well-being. But as Ashwin said, when there are family and societal factors, it can be contradictory. And then we will try to work a via media with infliction of as little suffering for the patient as possible. At the same time, without causing anguish for the family. But what Ashwin said also highlights the importance of more discussions on death in the society. Ashwin, you must write in the newspapers, everybody, or talk about it, teach about it. This is not only for medical students, it is for the public also. 2 generations back, everybody understood death. Now that it is a time of nuclear families, death is a stranger. And therefore, it is necessary to have a concerted effort with media's involvement to improve awareness of death and the intricacies of it. Now we have some time for questions and answers before we start the case discussion.
Thank you, sir. You can unmute from your end and ask your questions, or you can put them on the chat. Dr. Mohammed Sajid?
Good afternoon, sir.
Hi.
Sir, you have very rightly said that the communication should start very early. I think that's a very important point. Another important thing is, if we feel that, this is for your opinion, sir, if we feel that they are having some doubts about your methods, we can always ask them to get a second opinion and revert back to us if they feel that the opinion is safe. Because by doing that, we also get the feel that we are trying to do something for the patient, and they will also feel that, yes, why not get a second opinion? If the patient cannot be shifted, we can bring those doctors or bring those people to our institution and probably ask them to have a look and get an opinion in a transparent manner. Sir, your opinion, please.
Dr. Mohammed Sajid, where are you from?
I am in Malappuram, sir. I'm working in Malappuram, Kerala.
Okay. I totally agree, Dr. Mohammed. If the person is unhappy, as in that case, Ashwin said, they were unhappy with your decision. This is the kind of situation which may escalate into litigation and court cases. Very practical suggestion to get a second opinion. Unfortunately, Dr. Mohammed, there is also the situation that, especially in our country, 99% of doctors have had no education on end-of-life care. You are among the rare people who have studied this subject. So, majority of doctors will decide to ventilate. And sometimes we may have to say, by all means, you will have to take a call. We believe that this is the right course of action. Certainly, if you want to take him or her elsewhere, we will arrange an ICU ambulance for you. And part in as good terms as possible. But Dr. Mohammed, if in your town of Malappuram, I know there are several palliative care centers, you will get another physician in another hospital for a second opinion. I think that's a very good strategy, which will also reassure the family. Otherwise, remember, the family will live in guilt. Sharon, you have a question.
Yes, actually, it's just a comment on what we were discussing, Dr. Mohammed Sajid's question. So yes, what I found is just the fact that even within the same institution, but 2 or 3 different people from different specialties kind of saying the same thing, it kind of reassures them, especially when they are in denial. So that's why it's so important to have the MDT decision. And I suppose where I trained, I remember it was palliative care consultations would come just for explaining and reinforcing the prognosis and all that. Sometimes from medical oncology, sometimes from radiation oncology. So 2 or 3 people saying the same thing. I think that's 2 or 3 specialties saying the same thing, just reinforce that.
Sharon, where are you from?
I'm from Shillong, Meghalaya. Yeah.
Which institution?
No,
Sharon?
I'm right now just working in a private hospital.
Okay.
I suppose I was talking about my training and PG days and also yeah.
No, that's Sharon. Perfect. Totally agreed. If several doctors agree, that is reassuring for the family. But there is also a problem. Very often this happens, unfortunately. Even very recently, it happened to one of my patients who was in another hospital. I was one of the persons giving a second opinion. Practically everybody agreed. It was in a big corporate hospital, and they were all agreeable to withdrawal of life support. When the nephrologist appeared on the scene and said, no, how can we do this? We cannot do euthanasia. We must continue dialysis. And just because one doctor said this, the family continued to be very confused, and withdrawal did not become possible. The person stayed on a ventilator for several more days and died a miserable death. It happens. And Ashwin, yes, you are still talking about your individual experience. I totally agree that in spite of all that we are advising, not everybody, not in every case we can win the argument. There will be situations where everything that we try will fail and patients will continue to be suffering. Yes, we cannot always win, especially in the context of India, where there is no law covering it, where conventionally it is the order of the day to continue aggressive life support measures, even when apparently useless. So, Ashwin, I totally agree. I mean, we are not saying that in that particular situation, things could have worked. I totally acknowledge that when very often we may fail in everything that we have tried. And I'm totally with you on that. There was somebody else who wanted to ask a question.
Dr. Revati have asked, is there a
Revati?
difference of opinion what to do?
Revati, this is very, very painful, what I am going to tell you. But the truth needs to be told, however painful. Technically, okay, now we are talking theory. Technically, what the patient wishes should be done. But here we have a situation where the patient's wish is not clear and the patient cannot speak. How can the patient express a wish when he cannot read or write and when there is a tube in his throat? We don't know what the patient wants. And anyway, unfortunately, in the social situation in India, where a family holds the autonomy and can, every doctor knows that dead people do not go to court. Living family members will go to court. If I am dying, when my time comes, what I want becomes irrelevant to you because you naturally have to deal with my family and I cannot speak anyway. You will go by the family's wishes. So Revati, unfortunately in India, because we do not have a law, because the Supreme Court judgment puts in unrealistic rules, unrealistic procedures, we have a situation where you may have to be cruel to me just to please my family members, which is why early discussions are all the more important. And I can tell you, most of the time, we are successful in communicating with the family and arriving at fair decisions if we have enough time. If we are seeing them only on the last day of life, that will not work. I also want to show you one image. Now, there are two images here. One quotes an article in 2019 in Journal of American Medical Association, which is actually about practices in European intensive care units. There, they have shown that in almost 90% of cases, close to 90% of situations, when treatment is considered futile, when life is considered unsalvageable, artificial life support is withdrawn. Okay. Whereas Indian figures from 2021 show that only in about 30% of cases, artificial life support is withdrawn. In 70% of cases, meaningless artificial life support is continued till the patient dies on that artificial life support measures, destroying families financially and continuing and worse, continuing to inflict suffering on the family, on the person. So this is the reality. This is a situation that we want to change. Now I see that we have at least one participant from a high-income country. Ian Ferrer. Am I pronouncing your name correct? Do you mind me taking your name? You from UK. You must have.
Yes, I'm here.
Dr. Ian, you must have found it difficult to follow my accent. But you have any comment about the last slide and what I presented about the difference in figures of withdrawal life support between UK, between Western Europe and India? I'll show the image once more if you like.
Yeah, I found your talk fascinating and I could follow it all. And to contrast what you were saying between the two countries, because the vast majority of end-of-life care occurs within families and at home, that conversation starts much earlier. the primary care system is set up where you have to have a relationship with your primary care doctor in order to access secondary care. So you're often in a situation as a general practitioner where you are looking after a patient, but you've also known the children and perhaps treated the children as patients and even grandchildren. And you might have a relationship that goes back 5, 10, sometimes 15 years with that whole family unit. And that gives you a massive advantage in terms of your ability to speak and communicate effectively, and also credibility, because the children will know that you've looked after their mother before, you've got that person's best interests at heart, and they tend not to push back very hard at all if you approach it and take your time. And you have really this suggestion now that you should be thinking about end of life care basically for about a year before someone dies. So if you think someone's got a prognosis of less than a year, that's the time to start talking about what you would do. And often it's in a situation where people are in nursing home situations to plan in advance. So we very, very rarely end up with patients who are end of life or in an intensive care situation, unless it's been something very acute and traumatic. So it's a very different situation, and we are still learning in the UK to start those conversations earlier and to go work through all those processes. The other thing I would say is that often the patient themselves know that they are dying. They know that they don't have very much longer left to live, but we don't have societal pressures where the family are expected to do everything possible. And we only have one provider, which is the NHS. So you don't have the option of upping sticks and moving to different institutions, or doctor swapping, or moving hospitals, or searching for opinions. You will get, by and large, a very consistent message from the NHS, but we're still not good at doing it.
Ayan, may I call you Ayan? Call me Raj.
Please do.
This sounds like heaven compared to the situation we have found ourselves to be in 2 generations, moving on to nuclear families, moving on to a healthcare system without any primary care system, people going straight to multiple specialists, and the conversations about death becoming practically non-existent. We have a long way to go, and which is why I particularly think, friends, that in India, we need a neo-literacy campaign about death. Death is an unfamiliar stranger today, and different hospitals offer different interventions. And now it is also extracorporeal membrane oxygenation actually being used on dying people for weeks together, destroying families. So this literacy campaign, someday it will take a whole generation, will be the only thing that can prevent the calamity that Ashwin was talking about. Friends, I thank you, and everybody who participated in the discussion, Ashwin and Dr. Mohammed, Revat, and the others. Thank you for participating actively in the discussion. I'm glad I had the opportunity to talk to you. Dr. Sunil is here, who will take you through the case discussion to follow. Thank you, Sunil, for stepping in. I'm sorry that I have to leave now. Have a great evening, everybody, and have a great day within a different time zone, different friends. It was good to have your participation. Thank you very much.
Thank you. Thank you, sir. Thank you, sir. Excellent.
Thank you, sir, for that wonderful session. We'll
Thank
see
you, sir.
Dr. Sunil, are we good to start the case presentation?
Yeah, please go.
Dr. Ashwin?
Yeah, I'm here.
Yes.
Can you see my slide? Yeah. So we are presenting a 50. Can I next slide? So the 53-year-old male with a diagnosis of a metastatic CS stomach who had a BRAF mutation and a high tumor burden. Next slide. Yeah, so he was diagnosed with metastatic CS stomach and he presented with casualty with dyspnea, which he's been having almost for a month, and with the worsening of symptoms prior to the previous episodes. Next slide. So in short, he's been about to multiple lines of therapy, and last he was on immunotherapy and he had disease progression. And we had actually counseled him in view of disease progression that he would not be an candidate for further treatment. And a decision was taken that to put him on supportive care. And he was already from day one, since last 1 year, has been counseled. And because he had a rare mutation and the outcomes were poor, so it's been discussed multiple times. But they went to Bombay, got an opinion, and came back saying, give us one more round of immunotherapy, which we were not very happy to do. But because the family insisted on it, we gave him. But he came back again with worsening symptoms. So he had massive effusion and ascites, requiring multiple pleural taps and ascitic taps. And we had to put a pleural drain for him, a pigtail catheter for him to send him home the first time. The next time when he came, he had effusion on the left side, and he had a catheter again on the left side. Not an ICD, the small catheters which come now. So he had two catheters, when they would keep him at home and they would manage him with that. And whenever he was symptomatic, they would drain the fluid at home. But this time he came back with worsening symptoms in spite of having the catheters inside. Next. So when he came to me this time, the final time, he was an ECOG of 4. He had bilateral decrease agility, abdomen is distended, but there was no tenderness or any of those symptoms. Vitals were hemodynamically stable. Next. All these were the initial labs that we had. He had hyponatremia throughout his episodes, but we were not actually chasing it at that point of time. Next. The family and the patient at that point of time had really realized, and he was more understanding, but the family, the young children, where finances are not an issue, were still not willing to give up. And they felt that initially they were very upset with me for denying treatment, saying that we met so-and-so in Bombay, and they said you should not deny treatment. So every time he was in the ward, they were similar to this, but they were more educated.
Dr. Ashwin, you're muted.
And finally, next slide. So he was at that point when he had gone home was on multivitamins, paracetamol, lacilactone, Clexane, and some steroids. That is what he was on. Next. So this patient, the main concern is recurrent effusion, distress because of that, and he wanted to have a comfortable life towards the end. So at this point of time, we started on a morphine infusion because he was having secretions. We started on glycopyrrolate. And then towards the end, we gave him slow boluses of infusion midas at 0.5 mg per hour. And he was not in distress, and he passed away peacefully after 6-7 that night in the hospital. Next slide. So my question here was the fact that this patient had ascites, and I was always thinking that should I put in a drain? Will it really make a difference? Because the Flores catheter was expensive. They didn't have issues with finances at any point of time, but I know this patient would not have got through a week or so. So would it be justified in putting a Flores catheter? And in patients who are terminally sick, what is the role of TPN? If the intake is poor, patient's family keeps saying that they're not taking enough, they're not eating. And most of these, some subset of caregivers would prefer to stay in the hospital because a hospital can provide round-the-clock care. Now, there are two aspects to it. One, a private hospital, the charges can come up, and then for a private patient, it's okay, but for the majority of the patients, it is difficult to pay these bills. And in this patient, my question is, was sufficient palliation achieved?
Thank you, Dr. Ashwin. Can anybody comment on this questions? All of you might have taken care of many patients near end of life. So how do you manage what would be your opinion regarding these points raised by Dr. Ashwin?
Hello, good afternoon,
Yes,
sir. Nice.
yes, please.
Sir, it's a difficult decision to put a pigtail, but the problem is the ascites itself could be a reason why patient is unable to take some food. So rather than giving TPN at this moment of time, if we could remove some fluid and then probably allow the patient to take some food orally. Removing the fluid does not mean that all the fluid needs to be removed. You remove it gradually, little by little, probably keeping the catheter inside. Pigtail catheter can be kept for some more time. So that way, it would be a relief for the patient. Ultimately, we are all planning for palliative care only. So rather than giving TPN, I would prefer that the fluid is removed so that the intra-abdominal pressure reduces, patient is able to take some food or fluid, whatever he is able to take. That is my opinion on that part of the decision.
Yes, sir. So he already had, to begin with, he had this ascites and then the fusion. So 2 weeks before this, we had already put in a pigtail, that non-self-draining thing, and they would be at home and manage him at home. So initially we had a pigtail in the abdomen, then in the left lung, and then the right lung. So I thought I was crucifying him at the end of the day because I mean that is what I felt, because each time he came, we sent them back home, so they managed him at home for some time, and then finally when he came to the ward for the final time, I felt bad because there was a pigtail in the abdomen, there were 2 chest tubes, not chest tubes, you don't see it outside, but it was there. So my question is that did we really achieve palliation? They could afford it, yes, so it is not a problem, they were happy about it. But for those subset of patients who really can't afford, do I go this way? Is it really worth going this way, is a question?
I think we have to take the opinion of the patient as well as the relatives. If as your patient, probably patient and relatives, maybe this specific patient may be willing. Probably the next patient may not be willing. So in those situations, probably you take decision on a case-to-case scenario and then take a call on that rather than generalizing it.
Yeah. What is the cost of a pigtail catheter?
I mean, the one that we use is around 30,000 rupees.
30,000. Okay. So
the newer one, that's the thing. So
okay.
I didn't actually push for it. The family actually came back saying we spoke to somebody and they said, why are you not using this? Then, you know, it escalates from there to there. But I've used it for previous patients and it really didn't give me the result that I wanted, because these patients don't live a long time. So putting an expensive thing for me, actually, at the end of the day, even though it technically looks good, it's 90,000 rupees just for palliation. I mean, they could afford. So again, like Sir said, ultimately it depends on what the family really wants. But then whether that is ethically right is my question at this point of time.
I think in this patient, they were affordable, but if the question is whether the patient also wanted to have the same, was he willing to put the pigtail catheter, and were we able to explain it to the patient, and did he accept? That's all what we have to look in this, because
he was understood and he wanted comfort, and he was very clear that, you know, I don't want to struggle too much. So that was very clear from the time we were treating this patient. He was actually quite educated. So what I wanted to ask here is that most of the time in practice, patients bring parents and say, don't tell them diagnosis, don't tell them what is happening. Then how does the patient take an informed? I mean, it's very difficult for me to tell patients and tell them that you need to inform, because everybody has a right to know and understand, and everybody should understand what is happening. But majority of the time, the patient's relatives are very adamant saying that they should not know what is happening.
Yeah, that's very difficult, because even though we talk about managing pollution and we talk to the caregivers, but the problem is that some of the caregivers may not allow us to inform the diagnosis or prognosis to the patient. And suppose this patient was not informed about his condition, and caregivers, our family is insisting on to put the catheter, then patient will be in a situation, why are you putting this catheter? What is the use? There will be many questions which we have to answer. But in this patient, I understand that this patient knew about the diagnosis and he wanted this. So, and they were also affordable. And I am sure that will give a good symptom control because they will be able to drain the fluid as it accumulates. So it is as per the patient wish, getting good symptom control. That should be okay. But for those patients who are not affordable, then I think this may not be a good idea because of the cost, particularly the cost involved in it, even though it can give good symptom control. And have you come across any complications in these patients?
Not really, because I've only used it for 3 patients till now. Patients, I mean, you put the catheter, they go home and they pass away in 4 to 5 days. So that makes me upset because, I use an equipment which was, again, I thought should give them a bit more of time, but then they are already advanced diseases. It needs a surgeon to be put. So it needs a surgeon and an interventional radiologist to help you put this catheter because it's a tunnel catheter. So it's kind of sterile. Nothing is seen outside. It's convenient for patients because they just have to connect a specific vacuum bottle in which the water will drain automatically. But it needs surgical backup. It needs tunneling, and it needs interventional radiologist to help you do it. So that is one of the costs for this procedure actually.
Yeah, Dr. Rishikesh.
Yeah, I have a comment, and I might come off a bit direct, but saying that patients that can afford can go ahead with the treatment, while those not affording it might not be a good option. But if it is portrayed to the patient that, okay, this treatment costs such and such amount of money, but it will give some relief, I think many patients' families would prefer to pour in that money for a treatment which may or may not be that beneficial. So how do we deal with these situations?
If for an unaffordable patient, I will continue to do the usual tapping, like ascetic tapping, maybe every twice or maybe even we have some patients who continues to have, or we used to have ascetic tapping every other day. And there are some patients who need frequent pleural tapping, which we have to offer because it's our duty to provide symptom control. So that's all what we can do. Otherwise, we have to find out a sponsor or any other people who are willing to support. But it is a fact that without considering the economy or financial status, we have to provide symptom control in some way. Yeah, thank you, Dr. Rishikesh, for that question.
Could I ask something from perspective here in the UK? Sometimes we borrow from our pediatric colleagues who use what they call a triadic consultation model. Often for children 7, 8, or 9, you would be talking to the parents on one level and on exactly the same level to the child, and getting a perspective from both sides. So in this situation where it's been tricky in the UK, I've always tried to have any consultation with the patient themselves, plus a key member in the family that would be the decision maker, who would be appointed to speak from a family perspective, so that both the patient and the family had exactly the same information and could understand. And in that way, you facilitate also contact and communication between the patient and their family, so that what they wish as a patient is clear to the family and you get an agreed way forward. Because it seems here we're sacrificing patient autonomy on the altar of fear of litigation, which seems completely wrong. And moving to a triadic consultation model means that anything that you're going to do, particularly in this palliative situation, is agreed both with the patient and with the family's consent, which should hopefully steer the decision making down at probably an earlier palliation and less aggressive intervention. I don't know whether you try a triadic consultation model normally, or you negotiate independently all the time, or does the family always take priority over a patient? I don't know. You have to answer. I don't know the situation.
Yeah. Even though we all understand that autonomy of the patient is the superior or the most important ethical principle, the situation is like this. Usually the patients comes to hospital accompanied by the family members, and there will be the doctor will be mostly talking to the family members. It is the family member who actually take decision what to do, what should not do. All the decisions are taken by family members, and the family members may not involve the patient in that decision making. And if any of the doctor goes against their wish and talk to the patient, they will be very angry and they may take away the patient from the hospital, so that the doctor lose a chance to help the patient. This is a very difficult situation that we face. But it is also important to tell that most of the patients have good family support who will accompany the patient through the disease and until death. And they will be there with the patient to assist or give help, etc. So I think this situation will be little different from UK and US, where the autonomy is given the most importance. But we understand it is the most important, but this is the difficult situation that many of the, or usually in India, we face. The role of TPN, I think it was Dr. Mohammed who talked about draining some ascites so that sometime they will be able to take some food. But in case of end of life, we would not advise total parenteral nutrition, as it is not beneficial to the patient. As we know, if the patient, this is stage 4 cancer, and patient might have entered into the stage of refractory cachexia, where according to the evidence, a TPN or any other intervention is not going to be beneficial. So it's, but at the same time, we have to understand from the family perspective also. Family is very sad because their loved one is not taking anything. So we have to be very empathetic while we talk to the family members. And we have to make them understand why TPN is not an option at this point of time. So that's what we usually do. For this, you have to give some examples. And even we go up to tell them a story like this. Suppose there is a mango tree, and some plant parasite is growing on the mango tree. At first, the mango tree will not have any problem, but after some time, what will happen? The plant parasite will grow, and it will spread all over the mango tree, and the mango tree will gradually get destroyed. At this point of time, if you put some manure for the mango tree, it is not going to be beneficial for the mango tree. So an advanced cancer is like this. So even if you give TPN or something else, it is not going to be beneficial for the body. So something which the patient's caregivers can understand will give them good insight why TPN or things like that is not beneficial for the patients. The next one was caregivers preferred hospital stay as they wandered around the clock care. Yeah, this is, can anybody comment on this? Your experience?
Acceptable, sir, because it is their wish ultimately. Probably patient also doesn't want to go home because their expectations about the care are slightly higher than the usual people. So I think there is nothing wrong in them being allowed to stay at home, stay in the hospital.
Yeah, definitely. Here in this problem also, what is the wish of the patient as well as the family member? So when there is some mismatch between the patient and family, then the problem arises. Otherwise, it will not be a problem. And we also need to understand that the patients with metastatic cancer, stage 4, then they will be under maybe we should allow them natural death. So we will not make them to undergo through any CPR or things like that. But otherwise, to provide symptom control in the hospital, it should be, it should be according to the wish of the patient as well as the caregiver. But when there is difference of opinion between the patient and the family members, then we have to negotiate between them, and we will always try to stand with the patient. So we would need to do a lot of talking to the caregivers. So that's it. And was sufficient palliation achieved? Yeah, please, can anybody comment on this? What do you think? Yes, Mohammed Sajid says yes, yes. Dr. Vandana says yes. Yeah, so in this patient, as Dr. Ashin says, the patient died peacefully. So he had good symptom control. That's what we have to understand. So whether it's not only the physical aspects that we have to concentrate when we talk about good death, because the other things like whether the patient knew that he is going to die, whether he was able to involved in decision making regarding the choice of place of care, and there are so many things involved in the good death. So were you able to talk that also, Dr. Ashwin? Am I audible?
So I think I missed you.
Yes,
Yeah,
I hear.
yeah. I was asking, telling that it is not only the physical symptom control which is involved in providing good palliation. We know that you were able to provide him good symptom control, but were you also able to talk or were you able to involve the patient in the discussion regarding the care of the patient and his approaching end of life? So
We've discussed with the patient itself because he was understanding, and the reason of starting him on immunotherapy was all because he wanted it. This was an off-label use of immunotherapy in this patient because there was no evidence of using it by trial. So we had to take him to the tumor board. I explained to him what are the things, and I told him if it doesn't work, I wouldn't want to continue it beyond a certain time because this was based on a. So all this discussion had been done, and when we stopped the therapy, also we had discussed with him, and then so he was understanding. So listen that they came to the hospital also because he told me at home it is difficult for them to manage and see all these things. And the final time when he came, he was clear that don't put me on a ventilator. I don't want any of those things, and I only want my family to be with me. So this is one of the good areas that that we have. We always discuss these things with most of the patients, but the problem arises when the family refuses to tell the patient or bring the patient into confidence. I mean, many times they say don't let them know. That becomes a problem because autonomy is taken off, and I think that everybody should understand. So I try to ask the patient, do you want to know what is happening? But then sometimes two things I wanted to highlight is the fact that patients get admitted in the hospital. If you're in a busy practice like in a cancer center, you will have patients on palliative care and patients on active chemotherapy. So there will always be discordance between these two subset of patients because the leaders tend to talk, they tend to discuss, then they have a negative feeling. So a lot of things like that. So I feel a hospice thing is slightly different from a standard medical oncology practice. But then if you refer a patient or tell them, like I was in Nadia, it was difficult to tell the patients to go to the palliative care team to take further treatment, and that we would transfer to the next department. So they felt that the treating physician would never be a part of the treatment after that. So that disconnect is something that I've seen in my training center, and the reality, when you start working, is also totally different. So these are things which I find difficult.
Yeah, that's very true. Because when you suddenly shift the patient from you to another person, the patient will think that, okay, and now this treatment has come to an end, and now there is another person who is taking over. So it is, so that's why we always say that palliative care should be started from the time of diagnosis, so that there will be the trust has already been created between the patient and the team of both curative doctors as well as the palliative care team. So even if you shift the care after some time, maybe after a year or 6 months, if you shift the care from oncologist to palliative care, they may not feel much problem because they know that these were the people who were with us for the last 6 months. So this is very important. Yeah. Is there a final comment from anybody?